So Claire, I know there'll be panels talking about digital and neighborhood and whatnot, but this is a rare opportunity for us to hang out by the fireplace. The wine will be served shortly, and cheese, of course. So can you tell us a bit more about what neighborhood really is? Because I'm kind of confused. I read a lot of documents, but what is your vision of neighborhood to start off?
Well, do you know, so good morning, everybody. It's so lovely to see you all. I'm currently going around visiting all the ICBs. So you remember you'll know we published some guidance in March around the neighbourhood framework, and I'm just going around visiting, as Jay, who was with us yesterday, in a place called Barrow Hill. And the problem we've got with neighbourhoods, if I asked every person in this room, they'd probably come up with a completely different answer. And the problem is they're all right at some point in time. But I think the place we visited yesterday will stay with me. Well, it will haunt me, actually. We went to a community centre. So it was a meeting, the ICB. So it was Derby, Derbyshire, Nottingham, Nottingham City, Nottingham, and Lincolnshire. The ICB all came together. And we met in this community centre, which is, in a neighbourhood. And it was a place called Barrow Hill. And Barrow Hill used to be a thriving community, used to have a railway, had one of those, in Thomas the Tank Engine when the train goes on and then it's on a circle thing and it turns it around. They had one of those, so had one of those in a roundhouse thing that we tried to go and see and couldn't. And and it's a community decimated by war, so 72 people died in Gallipoli from this really tight community. And they have been devastated. They have got really high rates of unemployment. They've got really high levels of deprivation and no infrastructure. And we were taken on a tour around this neighbourhood health centre, and one of the trustees is an ex-GP. And he said he retired 2 years ago, and he has learnt more in the last 2 years as a trustee of this community centre about what makes people ill than he ever has done over 30 years of being a GP. But the bit that will haunt me, Natalie, one of the volunteers that worked there, she's been working there for the last decade. And she took us into this. She said, "This room's going to be our heritage room." So I naively, it's going to be about, about the railway and about the mining bit. And she went, no. In this room, we're going to remember all our volunteers have died. So the volunteers are made up of local people that have come from that community. And in 10 years, 12% of their volunteers have died through traumatic means, so either by suicide or by drug-related deaths or by trauma. And it's like, if we are not making things better for the people that live in places like Barrow Hill and they're not unique, then there's really no point in any of it. So that, to me, is what neighbourhoods has to be about, is improving the lives for people that live in such vulnerable states that all of us in the room have no idea because of the inherent privilege that we have.
So you obviously have the bird's eye view of the whole system, and it's a scary one, isn't it? Because of the variation and what it could be. So I hear your story, which is very touching, but how do we get people to get their stories out? What do you think is the secret to make that happen?
So there's a very dull bit about that. So one of the things that I've been doing as part of these visits is pulling together packs by each system, and I've pulled together the packs using my new best friend Claude from information that is in the public. They now start calling me Claudette because I cannot move without checking with Claude at the moment. But pulled together these packs from information that is in the public domain, and there is something about taking information through your boards, through health and wellbeing boards, through trust boards, through ICB boards, that the due diligence you have to do around a piece of work, that you are prepared to take it through a public board and publish it, that means that you make progress. And there is stark variation. So when I sort of present people with these packs, and they're based on NHS England data sets, on fingertip data sets, on the GP patient surveys, all this stuff, it takes about half a day to pull a pack together, but it's and it gives you the best picture, including CQC, GP CQC assessments and care home assessments. You start to put that all together into geography. It gives you a real complete picture about what people are doing. But people are not taking things in the public domain, and they are not talking actually publicly, particularly with their local authority colleagues, about this is what this means for our neighbourhood and our communities. And there are just some really simple things like taking things through public boards that would start to alter that perception. And then I will write this up when we're done, so we will get an overarching report that gives us this is what England looks like in terms of delivery against the neighbourhood framework. These are the policy gaps, these are the brilliant examples, these are the bits where we should do more to unblock it.
So there are many doubters, right? I bet you there's many believers, but also equal number of doubters on how neighborhoods or how the NHS can survive or will be saved. What is your personal pulse check when you are in the room, dealing with many different stakeholders? Do you get a sense primary care is going to still be the cornerstone of the NHS? What is your sense?
Yeah, it has to be. I'm a third generation GP. General practice is in my blood and is at the heart of everything that I believe in. And I think general practice is the close, and I'm saying general practice, not primary care. I'm deliberately saying general practice in terms of being. A lot of the stuff I'm trying to do through the neighbourhood work is almost getting back to what it felt like to be a GP when I started, which is being able to look after people in the context of their lives across the whole of their life, because that was a job that I loved, and it was a job where I felt I had real impact because of the changes, because of the joyous introduction of some of the technology, some of the advances that we've got. The world has got really complex. So to get it back to the simplicity of looking after people in a way that works for them in the context of how they live their lives, we've got to simplify what has become an incredibly complex landscape. And we sometimes get lost, that one of the places we went yesterday, they put up this flow diagram of everybody, and you'll all have seen them, about the number of different teams involved in one person's care, and they had like 3 different virtual wards that were all looking after all the same people. And it's not unusual to go somewhere and find that somebody with multiple long-term conditions is looked after by 6 different teams, all trying to be helpful. But in general practice is the one place where all that information comes back. And because we get all the letters and we get people that come in not beautifully curated. One of my things is that secondary care is like the zoo. Right? So all the animals are in their lovely cages and they're all bit, and you've got a map and you kind of know where you're going to go. General practice is like the jungle. It's like you don't know what you're going to get around the next person that walks in, and you don't know what they're going to happen. So the world is never going to be beautifully curated because it isn't. The world is big, hot, and messy, and so we've got to make it as easy as we can for people to access the care that they need. And that, to me, is what neighbourhood is about, which is why it matters.
Well, I think the reality is not just in the UK, but around the world, that it's still a very secondary care-centric world, right, in healthcare. Because I think it's about, the whole industry is about treating sick care, not healthcare.
Yeah.
So again, I know this is, this is a rare opportunity for us to have this private chat. And I know there's everyone watching and streaming. But do you face that kind of obstacles? Because I can only imagine the world you're in where everyone's trying to fix the money, talk secondary care. You must be a very lone voice trying to fly the primary care flag. Is that how you feel, or you think you have more support from the sort of from where you sit? So.
Well, I am a pathological optimist. You know that, and
much more sophisticated than me saying crazy.
Yeah, let's go pathological optimist. Yeah, let's do that. If you look at the stuff that's coming out, so I think it's one of Chris Whitty's things that says if you look at the NHS, you always feel that nothing is changing and everything is terrible. But if you look back at where it was 10 years ago, you suddenly go, wow, that is a massive change. So yes, people of course are talking about hospitals and the care that happens in hospitals. Of course it matters, and it matters to politicians, and it matters to anybody that's on a waiting list or anybody that's waiting for an ambulance. These things really matter. But if you look at the shift in the narrative that is coming out, everybody has got neighbourhood plans. Everybody can describe their neighbourhoods. Everybody now, going around, they've all got their integrated neighbourhood teams. They can now identify their most vulnerable people. That is a million miles away than when I wrote my report in 2022. So it's that when you start to look back at where we were, but we are all impatient because we know the impact that we can have and that we can make it much better. But sometimes you just need to stop and look back and see. And that's actually the joy on these visits. The other thing we do is the minute we've done something, we forget we've done it. So where it was in Humber, North Yorkshire, they were like, well, what you've done. So, oh, no, but we did that ages ago. It's like, no, many people haven't done what you did years ago. We need to keep a log almost of our successes because I think we're very, particularly in the primary care world, we're always really conscious of wanting to make it better all the time. And we're always focused on, and now that's the next thing we've got to sort out. Rather than sometimes we do need to look back and celebrate and go, actually, we have done a lot, this is improving. But it's going to feel slow. Because the change that we need to make is so big. But as long as we can keep nudging it in the right direction, and I feel that it is nudging in the right direction, then that is good.
So being a leader in the world you're in is quite a lonely place. Can you share some insights on how do you sort of keep motivated to keep going? Because I really want people to know you not just our National Director of Primary Care and all the great stuff you are, but you are a key individual and leader. So share some insights.
Yeah. So I know myself very well, and those of you, I get my energy by visiting and by listening and by hearing what it is really like and remembering about why it is so important. So there are more people that have worked in hospitals or not worked in the NHS than there are people that have got primary care expertise at the moment. But that doesn't mean to say we're ever going to stop trying but at least we are there. You could go back 5-10 years ago, you wouldn't have had me and Amanda Doyle there. You've now got me and Amanda Doyle there. It is getting better. But the way I maintain my energy by going out and by remembering why it's important and by listening. Because I think when you do these central jobs, it's really easy to get subsumed by the political power, by the relentless pressure that you are under. It is overwhelming. The hours and the inbox and the fear that you're going to miss something or the fear that you're going to get something wrong. And so I've been in nearly 3 years, and I have made a point of regularly going out to stay connected. And it is a thing that probably is the most important to me, but it's also has been one of the things that has enabled me to be effective and to remember why I'm doing it.
Mm-hmm. Well, I must say, personally, I've always been a secret admirer of yours. I just don't know how you keep all the plates up and keeping as many people as happy as possible, which is impossible, right? So it's a thankless job. But I appreciate everything you're doing, and I think you can count on us. And I'm sure everyone in the room, right, if you understand some of the pressures that leaders go through, right? Don't be the first person to throw rocks, because when you're in that position, I don't know if you do the same. So I think our chance for success is to stick together, right? And when I say stick together, I would strongly encourage primary care colleagues to not just think primary care is the answer or the savior, because we won't be successful without working as a system, right? So I think sometimes we get carried away in primary care, don't we? Because we want to be valued, we want to feel loved, we want to be the most important, but that isn't the prize, because we may be a winner and lose overall because something bigger has taken over.
Do you know, Vincent, when I started in my Surrey job, so I was the chief executive of the Surrey ICB, and I was like, it's great, I'm a GP, I understand this is going to be fine, because I understand the whole system. About 3 months in, having spoken to every other, so local authority, secondary care, mental health trust, voluntary sector, everybody thinks exactly the same. Every single leader of every single sector also thinks, if only I was in charge, then it would be okay, because I'm the only one that really, really understands, and actually nobody's listening to me. Even the hospitals, nobody's really listening to me. So that was one of my bits about actually, we all We all feel the same. And I sometimes get called, they refer to me, but I'm a bit, donkey from Shrek. It's like, pick me, pick me, pick me, pick me. Yeah, exactly, pick me, pick me. And actually, one of the things I have, a bit to your point, around you are often more effective when, a bit less donkey and a bit less, one of my greatest pieces of advice I was given was be yourself, but less so. And actually that was if you can let the other people come in as the voice of primary care and as the voice of system working, it is a lot more powerful than me being donkey going pick me all the time.
So guys, don't be a donkey.
So don't be donkey, not a donkey.
Don't be either. So look, I promised to make sure Claire could get away just before 11 because she's got a lot of commitments. So I'm already running a little bit late, but Richard hasn't given me the killer stare. He's a master at chairing. So can we give Claire a round of applause, please? So.